ko Debbie Wilson, tōku ingoa. Hi everyone, my name is Debbie Wilson. I am currently working at the Ministry of Health as Principal Advisor for Sustainability in the DHB Performance Support and Infrastructure team. And for those of you who don't know me, I did used to work at Counties Manukau, DHB Sustainability Manager for several years before this new role. We are delighted to be here and providing this webinar series to you all. And I'm really honoured to be here to facilitate today's webinar. We have Rick Lomax presenting today, and let me start with a brief bio, which I'm just going to read. That's probably what you can see me glancing to the side. Rick has been working in sustainability and health for over 7 years, providing consultancy services with a 3-year stint at the NHS Sustainable Development Unit, where he led the NHS's carbon, air pollution, water and waste footprint work, which was published in 2018. Pretty phenomenal. Rick basically undertook the analysis and trajectory modelling, which led to the NHS setting a net zero carbon target by 2050 and the fleet air pollution target by 2030. Big kudos there goes to Rick. We were very lucky to have him. He joined, he came over to New Zealand just under a year ago, and he joined Beca. And he's actually working with quite a few DHBs and hospitals at the moment, and much more generally across the sectors. So one more thing, can I please remind you to ask your questions in the questions and answers box as we go along. We will ask Rick to address your questions at the end of his session. That's it from me. Over to you, Rick. Thank you very much.
Awesome. Thank you for the introduction, Debbie. It's far too kind. Hopefully you can try and share screen, so fingers crossed IT doesn't fail me. Really, really grateful for the opportunity to speak to you all today and talk through some of the stuff that I was doing at the National Health Service with the SDU. And I'm more going to focus on a very practical example that I've been working with a New Zealand utilities company to kind of talk through how you would create a net zero carbon trajectory and kind of the value and some of the lessons learned and some of the things that might help you on your journey as well. So I'm going to talk through what basically took me 2 years in the NHS to do in about 3 minutes, which is both exciting and depressing that it took me 2 years. But what we did is we set out early doors. The NHS had been, since 2007, I think it was, been doing a carbon baseline of the entire NHS public health and social care system. So for an order of magnitude, the total footprint in 2017 was 27 megatons, which is about 1/3 of the size of New Zealand's total emissions, so not small. So we published this update in 2018 that Debbie mentioned. Then what we started doing was moving from the baseline assessment into a trajectory. So starting to look at the historical emissions on the dark blue line over the last 20, 30 years from 1990, which is the baseline year for the UK's greenhouse gas target. And we started looking at what's the kind of do nothing projection if we as a health sector stand to the side and not tackle climate change, where might our emissions lead to? And it's a pretty horrific trajectory and what that might mean for health. So we started to talk through what are the things that we know is going to happen nationally that the health sector can leverage, which is the stuff in purple. And we wanted to look at what the health sector could drive itself and really deliver in terms of efficiency and looking at more transformation. So we did that piece of work, and that involved into the NHS long-term plan. So we got the NHS to sign up to a net zero carbon target by 2050. Which was pretty revolutionary for the NHS to do. And we are working on the basis that covers all emissions. So our direct emissions from energy, water, and those sorts of things, but also all our indirect emissions as well, in terms of all purchased goods and services. So it's a stupidly ambitious target, but we really wanted to set that aim. And we'd rather fall short of a really aspirational aim than not be aspirational enough. But under the carbon target, the national carbon target for the NHS, we set some very specific goals. So we wanted to reduce the anaesthetic gas carbon footprint by at least 45% in a couple of years. We wanted to reduce the carbon impact of inhalers by 50% over a 5-year period. And that was also going to unlock a really significant financial saving around 15%. And the total NHS inhaler bill, I think, was $2.2 billion in 2018. So it's not a small saving at all. What we also did was got a target in to reduce air pollution emissions from the NHS fleet by 20% over a 10-year period as well. So it was really setting the macro level of what we wanted to achieve, but breaking it down some really achievable but inspirational kind of aspects of what we could deliver in the healthcare system. So that's evolved further since I've left the SDU, and what they've set up now is a Net Zero NHS Commission. So we're re-evaluating the evidence across the system, so a massive consultation exercise to check, is the wedges analysis that we did earlier and the trajectory analysis, is that still right, or do we need to reframe that? Because if you can notice in what we did in 2018-19, there was still quite a significant gap to get to an 80% reduction when we had the target for an 8% reduction by 2050. There's an even bigger gap to get to 2050. So the Commission's kind of role is to do some evidence gathering and then re-update the wedges analysis. Oh, sorry, I don't want to do that. Oh, that's unhelpful. There we go. So we're updating the wedges analysis, the SDU without me, are updating the wedges analysis to see what this call of evidence is going to provide and what more opportunities are there across the NHS to reduce emissions and get to that 2050 target. One thing I just wanted to kind of share is this is the a more detailed breakdown of the 2017 emissions. And I think the big thing to note is the big problems were in the medical equipment, pharmaceuticals, business service, and fuel. So because we looked at the total emissions chain for the NHS and the health and social care system, it really put into focus what our biggest problems were. And it really means that when you look at developing a trajectory, developing the emissions plan, you really want to focus on the big problems. We also wanted to really focus on the disproportionate problems as well. So MDR usage, so that's meter-dose inhalers who have a high global warming propellant in them. So they only treat 2 conditions and they're responsible for over 3% of emissions. So we really realized that that was a very disproportionate thing that we needed to tackle. So we wanted to focus on that. It's the same with anesthetic gases. So they're only used in surgical procedures pretty much. And they were nearly 2% of the carbon footprint. So another major disproportional problem. And I think one of the things that I've noticed since being in New Zealand, I think there's something like 1,000 registered anaesthetists in New Zealand. So in terms of really getting to the source of the problem and really engaging the right people to drive what might be quite a significant proportion of New Zealand's emissions in the health sector, actually it's, I say, relatively simple to engage a small number of people in terms of 1,000 people rather than trying to influence the millions of nurses that drive other decisions across the board. So it's a really useful one just to remember what are the disproportionate problems. And the other really useful piece of context is in the UK, but also in New Zealand, both governments are leading on decarbonising their grid electricity. So it helps you see the context of what's going on around you, and it means we can leverage that context to maybe move more of the fuel's carbon footprint into electricity space. It also means that if someone else is taking responsibility for a certain area of emissions reduction, it just helps us refocus on the areas that we need to double down on, which is really important, not to duplicate effort. So that was the experience in the NHS, and I just want to kind of bring this back to the New Zealand context. So I'm sure you're all aware of all of these, so I won't go into any detail, but it's just really useful to remember that there's lots of things happening in the space in a very short period of time, which is awesome. And it really means that the health sector can leverage a lot of this for change. So you all know about the Zero Carbon Act and the targets and the budgets that are going to be set. We all know about the Climate Change Commission. There was a restatement of New Zealand to get to 100% renewable grid by 2035. We know that the policy around the emissions trading scheme is starting to roll out even more, and there's potentially reforms to include climate change in the RMA as well. and we're potentially seeing guidance from MFE and other agencies across New Zealand that says the fleet transition to EV is going to be a really important part of New Zealand's decarbonisation. So all of this great stuff's happening. It's just about leveraging that change within the health sector. So this is an example that's not health sector, but it gives you an example of the process we need to go through as an organisation to develop a zero emissions trajectory. So this is a utilities company, so they've got both emissions in terms of normal greenhouse gases, but also biogenic methane. So that's why their target isn't to fully to net zero, because under the Zero Carbon Act, there's a different target for biogenic methane by 2050. So it's important to understand what of your emissions are included in the Zero Carbon Act for context and what isn't. But also the other thing we worked with this organisation was to understand what population growth might do for driving their emissions. So this solid black line is to represent a potential BAU scenario, business as usual scenario for emissions over time. So when you start to see the fact that it's going to grow over time, really emphasises the need to challenge and think about that now. And I think it's the same in the health sector. We know that population growth is probably going to be an issue for DHBs in terms of treatment, but we also know the types of cases and the acuity of disease that we're going to see over the next 30 years in most developed nations is also going to get more and more complex, and therefore we're going to need to provide support for people who will live longer and longer into their lives. So what we did after understanding the BAU was start trying to think about what are the opportunities to reduce against this BAU profile. So the utilities company I'm talking about here, they already had planned a demand management program. So we worked with them to understand how effective that was going to be. And this was a really early program in their kind of broad spectrum of their sustainability plan, but it was really useful for them to start seeing the impact of that over time. And it is only a small impact, but it was definitely a start, and they know they can do more on demand management. So it really helped visualize that that program was awesome, but it needed a lot more support. So then we looked at some of the New Zealand context, and as already mentioned, we know New Zealand's got a target to be 100% renewable grid electricity by 2035. So we looked at 3 different scenarios over time. Appreciate that target is set by government, but governments change and contexts change. So we looked at if we were going to slowly move to more and more renewable grid, these are the 3 different scenarios. So the sum of them means that the grid is 100% renewable. So it's moving that context into your operational understanding, which is really important. And then we also wanted to look at if the company moved a lot of their fleet to EV, as some of the key contexts they could do corporately, what would that also contribute to their emissions? So you can see through these kind of some of the context, some of the stuff they could drive, they're starting to reduce this BAU profile, which is awesome, but it's still not reducing it below where they are now. So it's a real useful reminder to the organisation that actually they need to go faster and further. And just to show 3 different scenarios, so the baseline is, this is the assessment we did in 2017. This is the bits that make up the 2050 BAU profile, and this is the impact of the different wedges. And the important thing to see, this purple box is electricity. So under BAU, if the grid doesn't decarbonise and there's massive growth in their population, this purple box suddenly becomes, well, remains the 2nd biggest problem for the organisation. However, under the context of getting to 100% renewable grid, it actually becomes I think it was the 7th or 8th biggest problem. So it's really useful to remind the organisation that don't start on the context of today, work back from what 2050 might look like, because it really reframes what the problems are, and it really shows that efficiency is going to get us part of the way. But actually, if we work back from 2050, we can start looking at what the transformation is going to be required at an organisational level, which applies just as much to health as to anyone else. So what we started doing is we're looking at further technical solutions working back from 2050 to build numerous wedges to offer additional carbon savings over time. And then the final bit of the work that we're going to be doing is looking at a carbon offset strategy. So really trying to put this at the very last aspect of their priority. So really trying to work on reduction before offsetting, but knowing offsetting is probably going to be part of the solution. So if that's buying carbon credits or exploring future technologies around carbon capture and storage. What would be really great to do with this organisation as well is some of this BAU profile includes some Scope 3 emissions, but it doesn't include all Scope 3 emissions. So what we're really trying to do now is work with this organisation to understand all the other emissions, because the vast majority of this under the black line at the minute is energy, it's gas, it's process emissions, but actually it's not including the entirety of their supply chain. So we're really trying to encourage them to think about not just the things they control, but the elements they really should be influencing. And appreciating the Zero Carbon Act just looks at goods and services that are generated within the New Zealand country boundary. But actually, if you really want to think about an organization's footprint, you need to think much more broader about the things that it consumes. And like a DHB, like this organization, buys a lot of goods and services from different nations. Appreciating that under the international agreements, all countries should be pulling their weight in terms of reducing emissions. But I think the health sector, because it's got quite a narrow supply chain on some of the bigger, more intensive aspects and products that you use on a daily basis, actually there should be some really good levers across health to engage with some of those bigger global suppliers. So lessons learned from the process of what we've been doing at SDU and in New Zealand. I think it's really good to make the point that on your first cut of trying to develop a trajectory like this, you're probably not going to get to net zero, but I think that's okay. I think we need to start the conversation, start the journey to really understand how much more work is needed. So I think it's about being brave and going for it anyways. I think it's really important to be clear about what scope you want to include in your trajectory and what you don't. And I think that's an organisation by organisational kind of conversation. But I would implore you to be as ambitious as possible and include as much as your scope 3. So for healthcare, I really think it's important to look at patient and visitor travel. I think it's really important to think about staff travel. And from the NHS experience, 60 to 70% of our emissions were purchased goods and services. So it's really important to try and tackle that problem as well. I think one of the key aspects that we learned at NHS and we're still continuing to work on is talking to everyone. There's lots of people out there that have lots of really useful information that can bring new solutions to the table. So talk to internal and external stakeholders. It's about brainstorming lots of ideas and understanding the levers you have. And a lot of those is the contractual levers that you might have as an organization. So thinking about how procurement can play a really important role in driving your net zero carbon outcome. I think it's really great to get runs on the board, and I've seen all the DHBs are, really progressing on their carbon agendas. And I think it's awesome the amount of progress you've made. I think my note of caution is to not sweat the small stuff too much and start trying to think about what medium to longer term transformation might mean for DHBs and the health sector in New Zealand. So thinking about things like how do we get more and more aligned to primary prevention, looking at different, more new and sustainable care models. And I say, please don't sweat the small stuff. Have a look at your greenhouse gas inventory and focus on the big problems. Don't focus on the smaller ones. So that's my lessons learned. And I thought I'd finish off quickly with some things about what can I do? It's always a good question to end on. So I thought I'd give 3 or 4 points about what a clinician or a frontline member of staff could do, and also what some of the decision makers could do. So I have the privilege of being married to an ICU nurse, so I learn a lot about the day-to-day operations of a hospital. And I think one of the things that she's definitely taught me is she's really good now at asking herself, well, do I need to use this? Is the clinical policy saying that I need to use this for the right reasons? And challenging some of those decisions on a day-to-day basis, because you think the number of nurses in New Zealand that have to make millions of decisions on a daily basis about using gloves, using gowns, etc. I appreciate COVID has definitely forced us to absolutely prioritize infection control. I'm definitely not saying we shouldn't, but there's lots of decisions that can be made on a daily basis. And I think, especially in the clinical space, especially if you're involved in prescription of MDIs or use of some of the more intensive anesthetics, is really asking yourself the question, do you need to use those? And for decision makers, I really stress the importance of undertaking a procurement baseline. It's being brave to understand the whole size of the problem, which I appreciate is scary, but I think it's really important. Open up the discussion about transformation. I think that's really key really assessing our business model of a healthcare institution within New Zealand, and really trying to come up with ways to make people happier, healthier, communities more resilient. Actually, the ultimate goal would be downsizing the size of the health sector in the first place, because a lot of the time we just treat illness, and actually wouldn't it be great if we were all really focused on keeping people out of hospital in the first place. And I know you all know this, and I know you all want that future as well, so definitely not teaching you anything new on that one, but it's always good to remind ourselves. And I think focusing on the biggest issues and working back from 2050 is really important, and also making the most and leveraging the change you're going to see at government and national level, I think is really important too. Cool. So that is a 20-minute whistle-stop tour through some of the stuff I've been doing at the SDU before I came to New Zealand, and some of the exciting work I've been doing at New Zealand. So really happy to kind of open up the floor to questions.
Kia ora, Rick. That was sensational. Some really key learnings and valuable insights there. Thank you so much for sharing those. We do have some questions. Yes, a person's asked for a copy of your slides, so we'll make sure that they get shared on the Otago Uni website. The first question is, what is demand management, please?
Yeah, sure. So in the context of the utilities company, it was actually managing the need for their services. So without actually saying the name of the utility company, who still haven't shared all that information with their stakeholders yet, I think the easiest way to explain it and translate it to health is about trying to prevent people from needing to even come through the door of a hospital. So it's, for those guys, it's about reducing the need for and the output of their service, much as the same as we would do as we thought about prevention for a healthcare organisation.
Very good. Easier said than done, hey? But yeah, with some strong population health strategies that would help tackling obesity, for example. But yeah, great answer. Another question's come through. Could you just explain a little bit more about what Scope 3 involves and includes, please?
Yeah, sure. So if we focus on health, because it's probably a bit easier to explain. So the definition of Scope 3 is indirect emissions that are usually downstream. So if we think about a hospital or a DHB is going to be using thousands of catheters, thousands of gowns and hats, all of those products and services will have been manufactured, created either in New Zealand or another country. So Scope 3 is all the emissions associated with the extraction, processing, transport and treatment of all those raw materials that make up the goods that we use on a day-to-day basis. The other aspect of Scope 3 is around like purchasing air travel, so flights, but also transport that isn't owned by a DHB. So that'd be staff getting to work, and that'd be patient and visitors accessing the hospitals and the DHBs. So we found, and I'm trying to remember the numbers off the top of my head, I think staff commuting and patient and visitor travel were two of the larger parts of the NHS footprint. I think overall they added up to something like 10-12%. So it's really important for DHBs to tackle when and why people need to travel to the hospital. So if you think about how you arrange appointments, using telehealth, getting patients to connect with the GP in primary care and using that to leverage connection with the DHBs to try and reduce their travel. And then it's about, if they do need to get to site, how do we reduce the carbon intensity of the way they get there? So using public transport, etc.
Yeah, so thank you for that. It shows you how massive an impact Scope 3 emissions do have on all large organisations, DHB included, and it's actually really tricky to measure the full impact of your Scope 3. And we have been trying over a number of years as a Sustainable Health Sector National Network and sustainability managers to do that. So one of the questions came in actually, where would we actually start in New Zealand to be able to incorporate procurement emissions in the DHB footprint? Because it's very hard.
Yeah, it's not easy. At Beca, we've been tracking our procurement emissions for the last 2 years now, I think. And it's like 80, 90, well, it's 90% of our problem. So for us, it's even greater because we don't have the same amount of estate as a DHB. And we're about to start a work with ADHB as well to do the carbon footprint of their procurement, which will be awesome. Essentially, just to simplify the process, what we do is we use a lot of the financial spend data from an organisation, whether it's the DHB or Beca, And there's several international databases that say for every dollar spent from a product that's made in a certain country, a certain part of the world, there's a certain carbon intensity. So the maths is quite simple. It's A times B. The difficulty is lining up the categories of how you organize your spend in an organization and choosing the right database and using the right factor. So we use one database within the NHS, which is really useful. There was a global report done by Healthcare Without Harm, and they used a slightly different database. And the work we do in Beca, and I'm going to use with ADHB, is a New Zealand specific database. So the art and science of carbon footprinting is relatively simple in terms of the calculation. The difficulty is making sure you make the right decisions to use the right factors.
Thank you so much. I'm just wondering, you know, should a DHB be setting a goal of achieving net zero carbon? How achievable is that?
So against the whole all emissions?
Yeah.
Okay. It's a difficult one. The way we kind of negotiated it, the NHS, was really setting ourselves to be really aspirational, to really set a global mandate that we should be trying to get everything to net zero. And appreciate right now we do not have the technology, we do not have the roadmap or the solutions to get to net zero yet. But if we don't aim for it, we're never going to get there. So I'm always the type of person, I'd rather aim for the stars and just about make it to the moon than only aim to get up the hill and definitely get there. So it's about talking to your organization about how willing they are to be really kind of ambitious and aspirational, or do they really want to set a target they know they can achieve? And my personal view is, collectively, if we all aim for the stars and we don't quite get there, we'll have got somewhere really fantastic. So that's still really important. And I think that's the type of conversation we should be having with DHB leaders, to say, hey, if we collectively all set that mandate that we really want to get here, actually that's really going to help the whole system shift. Rather than not being aspirational enough and seeing the downstream problems of not tackling climate change enough, with more people coming through the front door because we haven't held our own kind of system level approach in enough regard. And therefore the biggest bill payer in a lot of the downstream impacts of climate change is going to be local government and health. So if we don't tackle the problem, we're going to be part of the problem as well.
Well said, totally agree. Hey, we've got time for one more question, and there have been quite a few actually, so I will mention how you can get your questions answered if we haven't managed to answer your question today. This question links in the webinar in 2 weeks' time because it's about food. So what are your thoughts on getting more hospitals using less meat and dairy on patients' menus and at hospitals' cafes?
Yeah, I think that's awesome. It's about finding the win-win-wins. And I think moving to a vegetarian diet, you spend less money because meat is actually quite expensive. It's actually quite high carbon, and excessive red meat is actually really unhealthy. So to me, it's an absolute no-brainer. One of the things we found from the NHS is actually the carbon footprint of food wasn't huge, but the water footprint of our food was the highest by far. I think it was nearly 50% of the NHS's entire water footprint, 50? Might not be right, I'll have to check that. But it was the largest part, and it was helped us really understand that if you have several different lenses, so carbon, air pollution, water footprint, it really helped you understand the breadth of the problem. And once you know the breadth of the problem, it can really help you drive the right solutions and focus on the right elements. And I can't reiterate my point enough about not sweating the small stuff. If something is 0.5% of your carbon inventory, please don't focus on it. Focus on the areas that are more difficult. They're going to drive bigger change.
Fantastic. Ngā mihi nui. Kia ora. That was awesome. That was really good. Thank you, Rick, for a wonderful presentation, and thanks to everyone for joining us today. Please don't forget to tune in 2 weeks' time, which is a webinar which features Dr. Jeff Kira from the School of Health Sciences, Massey University, and the title of Jeff's webinar session is Health, Equity and Access to Food. If you have any unanswered questions, please send them to wellington-events@otago.ac.nz. I think the key take-home message from Rick is work back from 2050 and develop the plans to allow for the transformation required. Please remember to get active in this space, be a change agent. Whiria te tangata. Thank you. Kia ora, everyone.